I'm ready when you are.
All right, great. Corinne, are you ready?
Yep.
All right, go.
Dr. Spencer is an assistant professor in the Department of Pharmacology at the University of Minnesota Medical School. Dr. Spencer received her BS degree from the University of Alabama, Tuscaloosa in biology in 2006. She received her PhD degree in the neuroscience graduate program from the University of Texas Southwestern Medical Center in Dallas. Her postdoctoral training was in the laboratory of Dr. Peter W. Calavas at the Medical University of South Carolina. She joined the faculty at the University of Minnesota in 2018 as member of the Medical Discovery Team on Addiction. She studies the trajectory of neuroplasticity, neurochemistry, and behavior associated with addiction as a chronic, relapsing brain disorder. In addition to these research endeavors, she has shown a commitment to mentorship both inside and outside the lab. For example, she is the co-director of an early career Pathways to Success mentoring program for female identifying new faculty members at the University of Minnesota, established through her work with the Center for Women in Medicine and Science. When not in the lab, she enjoys running and cooking. Welcome, Dr. Spencer.
Thank you so much. Although I'll have to admit I haven't done much of the running lately. I need to get back in that. So today I'm going to talk to you mainly about what the title is, so metformin, and how maybe we can use a type 2 diabetes drug to target cocaine seeking. But before the first little portion of the talk will be some background and then touching on a little bit of one of the papers that I provided for you guys to read. To start out, I'll give some pre-acknowledgements. So just at the very beginning, acknowledge the people that did the work in my own laboratory. So on the top row are my first two lab technicians, Lexi Willard and Amy Chan, who really I treated as my first two graduate students. Amy Chan has now moved on to actual graduate school. She's in her first year at OHSU. And on the bottom row are two undergraduates that also participated in the study, Allegra and Noor. And then not pictured is actually, so one other current graduate student who rotated in my lab, but joined another one. I'm still on our thesis committee, but she did the very first experiment for the metformin study. So obviously they get almost all of the credit. So first, I'll start out with a little bit of background context, and this is to remind you about the scope of the problem in the United States and to emphasize that there's an ongoing addiction epidemic and not just an opioid problem. And so we know really that these things can be cyclical in terms of drug abuse. And so this is important because while we're in the midst of an undeniable opioid crisis, we can't be lulled into a false sense that other drug problems have disappeared. And so the graph on the left shows age-adjusted cocaine overdose mortality rates. And you can see that those have been dramatically increasing over the past 10 years. And opioids do compound that problem because a rise in stimulant-related ER visits and overdoses is also due to substances being laced with potent synthetic opioids like fentanyl. On the right kind of illustrates again how this can be a regional issue. So this is drug seizure data from 2015 and 2016, highlighting that in the Twin Cities area, so Minneapolis, St. Paul, where I am right now, the two most frequently seized controlled substances were actually methamphetamine and cocaine, and not heroin or opioids. So for many regions of the country, there's still an addiction crisis that isn't exclusively an opioid crisis. And importantly, cocaine use disorder, remains a significant public health problem. And so this further highlights some of the immense costs associated with both legal and illicit drug use in the United States. And so that can be stemming from healthcare costs, crime-related costs, lost economic productivity. And so the graph on the left is adapted from the National Institute on Drug Abuse, showing overall and healthcare-related costs associated with each of those substances of abuse. And so at the time of this data, which was from 2007 to 2013, it was over $800 billion worth of costs, but now it's predicted that that has risen to over $1 trillion per year in costs related to substance use disorder. On the right highlights that this is sort of a problem that we're not doing a great job of fixing. So A and B are sort of survival distribution curves, or people that remain abstinent from each of these different drugs of abuse, with data from the Hunt et al. Paper being a 1971 paper, and on the right, a 2011 paper. And you can see that relapse rates across all of these drugs still hover around 50%, and that hasn't improved in 40 years. So despite decades of research, for some substances abuse, we still don't have great treatments. And for something like cocaine, we actually still have no treatment. So in my lab, we actually use a rat model to study addiction. We use multiple sort of rat models, with the main one being the cocaine self-administration, extinction, and reinstatement paradigm. So rats are given a surgery to implant a jugular catheter, and then we can put them into an operant box that's equipped with 2 levers and multiple lights and a tone generator. And so we can hook them up to that implanted catheter, and they can learn to press one of those levers, the active lever, to deliver themselves their own drug infusion. And so for our purposes today, that drug is going to be cocaine. So rats learn to lever press on the active lever for cocaine and to not press the inactive lever. And so over a period of time, for these particular studies, they need to reach a criterion of 10 days. They learn that behavior, and then we can move them on to the second phase of the experiment called extinction. So during extinction, it's like we're forcing them into rehab. So we bring the rats back to the operant boxes. They still get the levers extended, but now when they press either lever, it has no program consequences. So they learn to inhibit that responding on the active lever. Then in the final phase of the experiment, we bring them again back to their drug taking context, but now we can bring back something like those previously drug paired cues. So in our case, a light and a tone, and that cue or those cues remind the rat of getting cocaine during that first phase. And so now they reinvigorate their lever pressing. And so in the rat, we call that reinstatement, but that's our model for relapse in the human. And so what we're interested in doing, or one of the things we're interested in doing, is seeing if there's ways that we can intervene on any of these stages. And so if there are things like pharmacology or neuromodulation that could be performed at any of these stages to, for instance, decrease or reduce reinstatement or relapse. And so the first little part beyond the background, I'll talk about the first sort of, I guess, addiction study I ever did. So the first study that I did in my postdoc in the Clibus lab. And so looking at this drug, gabapentin. But on the top, I'll first highlight kind of a strategy that we're looking at taking in my lab, and that, in a lot of sort of neuropharmacology has been interested in applying. It's this idea of drug repositioning or drug repurposing rather than de novo drug discovery. So de novo drug development can take, up to 20 years and actually has less than 10% probability of success. So it takes a long time, it's very costly. In comparison, drug repositioning, so looking at a compound that's already safe and approved, can drastically reduce the time. So anywhere from 3 to 12 years instead of 20 years, and you have a much higher probability of success due to known safety and pharmacokinetic parameters. So just keep that in mind. And gabapentin itself is a prime example of sort of drug repurposing or drug repositioning being successful. And so gabapentin was originally developed as an anti-epileptic drug, but it's seen success, or is touted as one of the successes in drug repositioning as it's now also used for neuropathic pain. So shown here on the right are the structure of GABA and gabapentin. So gabapentin is an amino acid analog of GABA, and as an anti-epileptic, the idea is wanting to sort of renormalize the excitation inhibition balance. So increase inhibition, decrease excitation. So I think it was originally sort of developed to be this GABA drug, and it does increase GABA, but it doesn't actually bind to GABA A or GABA B receptors. It was eventually found that it's actually it's a high affinity binding site at the alpha 2 delta 1 subunit of voltage gated calcium channels. And that's how it decreases the release of glutamate from presynaptic terminals. And its role in neuropathic pain is also through this alpha 2 delta 1 mechanism, or at least one known role is this mechanism, is that it can normalize the aberrant interaction between the NMDA receptor and alpha 2 delta 1 that's involved in the development of neuropathic pain. So the first study that I did in my postdoc, so transitioning from my PhD, where I worked on circadian rhythms and mood disorders, and really did sort of mostly molecular biology and gene expression work, stemmed from another study that had been done by Kate Reisner, that was a postdoc in the lab at the time. So she did this proteomic screen that was looking for proteins that were significantly changed by cocaine self-administration and extinction. So just ran some rats through that paradigm, took out a section of the brain, the nucleus accumbens, that we know is important in addiction relapse, and saw what she could see. And so one of the things that came out of that was this calcium channel alpha 2 delta 1 auxiliary subunit. And she saw that it was, so here things that were downregulated are in bold, and things that are upregulated are in normal print. And so this was upregulated according to this proteomic screen. And so when I came into the lab, I wanted to validate that by doing Western blot on nucleus accumbens punches. And so when we looked at punches from nucleus accumbens after cocaine self-administration compared to yolked saline rats, so rats that still went to the operant boxes, but they only got saline infusions, we saw that there was an increase, and there was indeed an increase validating this screen in alpha 2 delta 1 in the nucleus accumbens. And this seemed to be specific to the ventral striatum, as we didn't see that same increase in the dorsal striatum. And so really where gabapentin came in is sort of using it as a tool to validate this or determine the significance of this protein finding. So gabapentin is a high affinity ligand for this protein that we see is upregulated. So what's the significance of that if we give gabapentin to these cocaine experienced rats? And so what we found was if we microinjected gabapentin into the nucleus accumbens core prior to a cocaine primed reinstatement session, so in this case, in contrast to Q-induced reinstatement, we just give a experimenter administered injection of cocaine prior to putting them back in the box. And that subjective experience of feeling the cocaine again is what promotes the increased lever pressing. So with gabapentin microinjection, we were able to reduce that cocaine primed reinstatement. And looking at the physiological level, we saw in the nucleus accumbens core sort of effects on that glutamatergic signaling, sort of expected effects on glutamatergic signaling. So a decrease in the EPSC, so excitatory postsynaptic current amplitude in our gabapentin treated slices in our cocaine experienced rats, and an increase in the paired pulse ratio with gabapentin treatment in the cocaine rats. And so again, this kind of validated what we know about this mechanism in terms of gabapentin targeting this alpha-2 delta-1 auxiliary subunit of calcium channels. We also hypothesized in that same paper a little bit about sort of this thrombospondin mechanism. So thrombospondins are endogenous ligands for this alpha-2 delta-1 subunit. And so we hypothesized that that's another action that it's taking. And we already discussed that NMDA receptor mechanism for pain. I brought this up in the context of drug repurposing. And so to be fair, I'll tell you a little bit about what we know about gabapentin in the clinic in terms of its use for substance use disorders. So when I looked at clinicaltrials.gov last week and looked up gabapentin and substance use disorders, there were 11 studies there that were currently active or recently active. So what this data here shows is that 10 years before we ever did our study in the rat model, there had actually already been a human lab study that looked at gabapentin's effects on cocaine use and subjective feelings. And so what this shows on the top so these are cocaine doses, puffed cocaine doses on the bottom in mgs. And then these are the ratings of good drug effects, so the positive subjective effects of cocaine. So we're going to focus on the second cocaine test. So that's after, I think, 2 weeks of one of these doses of gabapentin treatment in human subjects. So we can see that gabapentin was able to sort of modestly reduce this good drug effect specifically at this intermediate dose and the highest dose of gabapentin in these cocaine users. But down here on the bottom, so this is cocaine choice, so the actual amount of cocaine consumed. And with gabapentin, there actually wasn't any difference in the cocaine choice measurement. So sort of this mixed, mild effect. And that's actually sort of kind of in line with the full picture of what we saw in the rats in terms of the behavior. So first, I showed you this positive result, so this decrease in cocaine prime reinstatement in our rats with gabapentin injection. But what I didn't show you until now is that when we looked at that Q-induced reinstatement, so that kind of reinstatement that I introduced first, gabapentin really didn't have an effect at all on Q-induced reinstatement. And so sort of altogether, these are in line with the overall literature in terms of gabapentin's effectiveness for psychostimulants, which looks like the verdict looks like perhaps not going to be an effective treatment. Where there is perhaps maybe a little bit more promise is in terms of the alcohol use disorder literature. And so this is a fairly recent study of gabapentin in a clinical trial. And here they found that there was an interaction between sort of gabapentin treatment and initial alcohol withdrawal score, such that those individuals with gabapentin treatment plus a high initial alcohol withdrawal score showed the highest number of no heavy drinking days and days abstinent. So perhaps there is some promise in terms of gabapentin as an anti-addiction medication, but maybe more specifically for some drugs of abuse compared to others. And perhaps this effectiveness in alcohol belies its sort of mixed GABA glutamate mechanism of action. But for the rest of the time, I want to talk about now the first study that I did in my own lab. So that was the first study that I did in my postdoc. So this is the first study we set up in my own lab at Minnesota. And so here we want to ask if we can repurpose a type 2 diabetes drug, so metformin, to treat cocaine use disorder. And so metformin was identified in the early 20th century, or well, the compound that it's derived from was identified in the early 20th century from the French lilac. And chemists found that that this drug could lower blood glucose levels in animals, but it was also toxic. And so they could make the compound more tolerable by bonding two guanidines together, and so forming a biguanide molecule, thus its chemical name. It was first synthesized in 1929 and then clinically developed in the late 50s for use in Europe. It wasn't approved for use in the United States until 1995, but by 2018, it's become the fourth most prescribed medication in the United States. And so it lowers blood glucose, improves insulin sensitivity. And so usually at this point, when I introduce that we're trying to use this drug, metformin, for cocaine use disorder, people ask about the link between diabetes and substance use disorders. And so I put in a little bit of a sort of detour to discuss that briefly. And so what is the link between diabetes and substance use disorders? The strongest link exists in terms of smokers or tobacco use disorder. So tobacco smokers are 30 to 40% more likely to develop type 2 diabetes. And the mechanism behind that seems to be starting to be elucidated. So there's a pretty cool paper that came out late 2019 that showed that transcription factor 7, like 2 or TCFL2, within the medial habenula is involved in the mechanism whereby nicotine is able to increase blood glucose levels. And so kind of one of the control experiments that they did in this report was just to acutely inject nicotine into a mouse and then measure blood glucose after 30 minutes. And so you can see with this 1 mg per kg injection of nicotine, there was a significant increase in blood glucose levels after 30 minutes. I bring this up because they also did some other cool controls in terms of comparing this to other drugs of abuse. So they did the same thing with an acute cocaine injection and an oxycodone injection, so an opioid. And so we'll focus on the blue because cocaine's our subject today. And so with a pretty high 20 mg per kg cocaine injection, after 30 minutes, they didn't see an increase in blood glucose levels. So not the same sort of acute effect on blood glucose. In terms of kind of what's known clinically, there's not a ton of studies, but in 1 or 2, cocaine was shown to be associated with or a risk factor for diabetic ketoacidosis. But in another more recent study, there was no association found with hyperglycemic crisis. And this more recent study examined active cocaine use. And so sort of in summary, what it seems like is, or what we know is that cocaine increases counter-regulatory factors, so things like ACTH and cortisol and catecholamines, and that these things, these changes can impact blood glucose, so and alter carbohydrate metabolism. And so it seems to be that probably there's these indirect effects on glucose production and glucose tolerance that are mediated by cocaine, in addition to in terms of when there's comorbidity with a diabetic condition, it can lead to poor outcomes because of drug use impacting, say, medication adherence. But this, I included this because I just think it's a really cool study. So this study looks at prenatal stimulant exposure. So here, amphetamine, cocaine, and methamphetamine, and then looks at impacts on glucose tolerance in offspring. And so they found that in female offspring only, 6 weeks after birth, after exposure to these stimulants, there was a decrease in insulin intensity in the pancreas. So this effect on insulin staining normalized by 1 year, and so that's this middle panel. But what's interesting, even though this insulin staining normalized, there remained to be this functional sort of deficit in terms of glucose intolerance in female offspring at this 1 year time point. So there seems to be some sex-specific sort of lasting impacts of prenatal cocaine exposure. And so kind of that's the end of our diabetes detour. But so back to the drug that we're interested in. So really we were interested in metformin, not because of its impact on diabetes per se, because I just showed you at the time, there wasn't really any or strong evidence connecting the two. But we were really interested in the drug because of its known, or one of its known mechanisms of action. And so this shows a diagram of multiple mechanisms of action associated with metformin. The most well-known or most touted is this inhibition of mitochondrial complex 1 that leads to the activation of AMPK. So it increases AMP that activates AMPK. So it also does these other things, but this AMPK mechanism is what we were really the most interested in. So what is AMPK? So AMPK stands for adenosine monophosphate activated protein kinase. So it's a serine-threonine protein kinase with 3 subunits. And so it's a cellular energy sensor that senses an increase in AMP compared to ATP, and that leads to its phosphorylation of the catalytic subunit, which increases its activation by 100-fold. So it's expressed throughout the body, but it's also highly expressed in the brain. In the brain, it's rapidly activated following synaptic activity. Its activity is required for long-term memory formation, but its hyperactivation is also associated with Alzheimer's disease pathology. I'm going to put an asterisk here because sort of some of that data relating to whether AMPK is pathological or helpful in AD is a little bit mixed still at this point, but it seems that the activity of AMPK does need to be fine-tuned to some degree for optimal performance within the brain. And so we came to be interested in this protein because it was shown that AMPK activation, either genetic or pharmacological, was able to reduce Q-induced reinstatement for cocaine. And so another group, used that same assay already described, although in this case, the rat's nose poked instead of lever pressing. But here they, on the left, use a genetic approach. So either gave an adenovirus with constitutively active AMPK in gray or dominant negative AMPK in black. And they were able to bidirectionally influence this active nose poking or the Q-induced reinstatement response following cocaine self-administration and extinction. They also looked at this pharmacologically. And so when they gave this drug ICAR, which is an analog of AMP, they were able to decrease Q-induced reinstatement as well. But this drug ICAR has low brain penetrance and relatively poor absorption. It's also associated with some other adverse side effects. So not necessarily going to be very translationally relevant or something that could continue to be translated. So really what we simply wanted to do was determine if we could replicate that ICAR study using metformin, which is FDA approved, does readily cross the blood-brain barrier, and has high safety already associated with it. So can we use this drug repurposing or repositioning strategy with something like metformin, with the first step being to just see if we replicate that ICAR finding. So we used our cocaine self-administration, extinction, and reinstatement model. And here at the reinstatement phase, we decided to do a within subjects crossover design so that each rat is going to end up being its own control as well. So in separate sessions, separated by at least 2 additional extinction days, they'll either get a metformin microinjection or a vehicle microinjection into the nucleus accumbens core. And we did a parallel experiment, but using sucrose as the reinforcer. So we did sucrose self-administration as well, because we wanted to see if indeed we did get any effect of metformin on Q-induced reinstatement if that effect was specific to drug or if it was going to generalize to a natural reward like sucrose. And so we did these studies in both male and female Sprague-Dawley rats. And so Sprague-Dawleys are just kind of super commonly used outbred strain for things like this. And one reason that we wanted to do them in both male and female rats is because we know that there are sex differences in terms of substance use disorders. So there's a greater prevalence of substance use in males, although that may be largely driven by more societal factors. In females, we know that there's more rapid escalation of drug taking. They should show greater withdrawal responses, and there's also more craving during abstinence. And so that's derived from both clinical and preclinical literature. But the preclinical literature has allowed us to kind of begin to understand some of what might be happening in the brain associated with those differences. So a number of studies have begun to identify basal differences in different things involved in dopaminergic transmission in females relative to males that could explain some of these differences. We also wanted to look in both sexes because there are several studies that sort of separately indicate a greater metformin effect in males or a greater metformin effect in females. And so in terms of showing greater effect in males, it's been shown to have better glucose lowering effects in diabetes, and there was a selective inhibition of pain in a spared nerve injury model in mice for metformin. In terms of having a greater effect in females, metformin lowered mortality in female colorectal cancer patients specifically. And there are also specific cardioprotective and anti-inflammatory effects observed in young female mice. So there's enough evidence to kind of indicate that maybe we might see something skewed towards one or the other to do both. And this just, it's probably a little bit misplaced, but this just shows our strategy for kind of selecting the dose. So I don't think I pointed it out on the sort of experimental design slide, but we microinjected 125 micrograms metformin per hemisphere into the nucleus accumbens core. And so that was based on looking at studies that had shown an increase in phospho-AMPK, so an increase in the activation of AMPK associated with an intracranial infusion of metformin. And so here they did an ICV injection of 200 micrograms into the third ventricle, found a behavioral effect, and then also showed an increase in phospho-AMPK in the hypothalamus. And so again, this behavioral effect is increasing food intake. So the study, we looked at cocaine self-administration and extinction as described. And in general, we're going to have the male data on the left and the female data on the right, with green versus purple. And here, although there's sort of the appearance of more variability in the females in these first couple of days of self-administration, if you statistically compare the lever pressing across the experiment, it's not different. We did dig a little bit further into the self-administration behavior between our males and females. And so on the left, we looked at cocaine infusions across the 10 days of self-administration. Here again, there's no difference in cocaine infusions between the males and females. However, I should point out that we did use the same concentration of cocaine for both males and females. So if this is converted into a dose by weight measure, our females end up taking significantly more cocaine compared to our males because they weigh less. We also looked at discrimination index across self-administration and extinction. And so this is a measure of how well the rats distinguish between the active and the inactive lever in the box. And so during self-administration, both males and females, both reach basically near perfect discrimination in terms of choosing the active lever or pressing the active lever over the inactive lever. But we do see this sex difference emerge during extinction, where sort of more expectedly, the males show this decrease in drug discrimination over the course of extinction sessions, but the female rats keep very high levels of lever discrimination throughout the extinction session. So they never decrease their discrimination. Last, we looked at kind of what we're most interested in, this cue-induced cocaine seeking within subjects crossover design of saline or metformin microinjection. So to orient you, so the leftmost bars are the extinction, so the extinction sessions. So the last 2 extinction sessions prior to each of the reinstatement tests with saline or metformin. And so as expected, there's low levels of lever pressing during extinction. And so when we pre-treat with a saline microinjection, we see the expected increase in active lever pressing in response to those drug paired cues in both our males and our females. So we get cue-induced reinstatement. With our metformin microinjection, so in our males after metformin microinjection, what we end up with is this sort of intermediate level of active lever pressing. And so it's not significantly different from saline, but it's also not significantly different from extinction. In our females, we get something that's a little bit more clear. So in this case, this is still with metformin pretreatment, there is still a significant increase in active lever pressing. So there's significant reinstatement, but it is also reduced compared to saline pretreatment. Overall, we take this to mean that metformin was effective in both sexes, but the data is a little bit clearer, perhaps because of the sort of increased magnitude of responding overall in our females compared to our males. And we did sort of look at this a little bit closer by examining cumulative active lever pressings in 5-minute bins over the course of the 2-hour reinstatement session. And that also kind of helps you see kind of what's going on with the data a little bit easier too. So in our males, we see that over the sort of the first hour of reinstatement, there really isn't any difference, and that doesn't emerge until the 2nd hour of reinstatement. And indeed, if you were to analyze the hours separately, this first hour is non-significant, and the second in a cumulative or in a summed fashion. The first hour is non-significant, and the 2nd hour is, which you'll see on the next slide. And in our females, you see, so again, consistent with what we saw in the BIND data, the significant difference, but it begins to emerge earlier. So sort of within the first 30 minutes, you're starting to see a difference between the saline and metformin pre-treatment in the females. I have 2 slides. We also looked at the locomotor activity following a metformin microinjection in our males and our females. So we wanted to make sure that any decrease in lever pressing that we were seeing wasn't just due to a decrease in locomotor activity. And here, because we only wanted to test each animal once for locomotion, this is going to be a between subjects comparison, no within subjects. So following saline or metformin microinjection in the Spagdoli males, their locomotion across the 45-minute period is completely indistinguishable. With the females, this is also not a significant difference between saline and metformin treatment. And if anything, there appears to be maybe the tendency for metformin to increase rather than decrease locomotor activity. So at least we know that our reinstatement effects don't seem to be due to just decreasing their ability to move. But so that locomotor activity data was done within the first 45 minutes after a microinjection. And so we did that before we had looked at this cumulative active lever pressing data and saw this potential time-dependent effect in our males. And so after we saw this, and again, this not significant first hour, significant second hour, we wanted to go ahead and do some more locomotor activity in the female or in the males and make sure that we didn't see sort of a second hour locomotion effect emerge. And so here, the rats were microinjected, put back in the home cage for an hour, and then tested on locomotor activity. But again, we don't see anything emerge in terms of effects of metformin treatment on locomotion. Throughout the study, we also took vaginal cytology samples to score estrocycle phase during the experiment. And so shown here is sort of the comparison of the rodent estrocycle to the human cycle. And the rat estrocycle is much shorter. So it's a 4-day cycle that you can fairly easily classify based on the appearance of cells in these samples. And so we scored that throughout self-administration and extinction to see if perhaps any variability that we saw in our female animals was explained by estrocycle phase. But as you kind of saw by the data, there wasn't that variable, and we didn't really see any estrocycle phase effect during cocaine self-administration. And so there was no effect on active lever pressing, effective phase on active lever pressing during self-administration or on cocaine infusions during self-administration. We looked at day 1 extinction. And so of course, since this is 1 day, we have far fewer observations. So we bend proestrus and estrus compared to met estrus, diestrus based on hormone levels. And so here we did see this sort of day 1 extinction effect with higher active lever pressing during proestrus estrus compared to met estrus, diestrus in our females. And this is kind of consistent with what we do know in terms of this proestrus estrus phases sort of promoting reward-like behavior in females in other studies. And so we did all of this again, but looking at sucrose self-administration. And so again, we wanted to compare whatever we found with cocaine self-administration to see if it was selective or generalized. So sucrose self-administration in males on the left and in females on the right. And here in this case, we actually do have a difference if you compare lever pressing between males and females, with higher lever pressing emerging, especially during this FR3 phase. And so that's meaning when the rats have to press the lever 3 times to get 1 sucrose pellet, we see this higher lever pressing in females compared to males. And what this results in here on the left is an actual increase in sucrose pellets earned in the females compared to males. So they're taking more sugar rewards compared to males, which is also consistent with prior literature. We again looked at this discrimination index across self-administration and extinction. Here again, sort of the females are, they pick it up really quickly, and they again sort of tend to keep their discrimination high across the study, including in extinction. Whereas it takes the males a little bit longer to reach full discrimination. And during extinction, they again reduce, although not to the same extent as during cocaine self-administration. So finally, we looked at Q-induced sucrose seeking and effects of metformin here. And so here's maybe where the most interesting sex difference between the sexes emerged. So on the left, regardless of whether there was saline pretreatment or metformin pretreatment, we see significant Q-induced reinstatement of sucrose seeking in our male rats, and it's really equivalent between the 2 pretreatments. Here on the right, With saline pretreatment, we see significant cue-induced reinstatement of sucrose seeking. Now, here with the metformin pretreatment, I mean, by eye, we can see that there appears to be a decrease compared to saline pretreatment. Statistically, it says it's not significant. If I remember, I think this is like a 0.055. And on the next slide, you can see why I'm going to go ahead and interpret this as being a reduction actually in the female rats. And so if you look again at this data more finely, looking at the cumulative active lever pressing across the 2-hour session, kind of as indicated by the summary data, saline metformin treatment is indistinguishable in the male rats, but in the females, you can see sort of across the whole entire 2 hours that there's this significant difference in active lever pressing comparing the saline pretreatment to the metformin pretreatment. So it seems as if, whereas we have maybe a selective metformin effect on cue-induced reinstatement of cocaine seeking in our male rats, we have this more non-selective effect in our female rats that's generalizing to a natural reward. And we again looked at estrous phase effects on sucrose self-administration, and we again don't see anything here in terms of active lever pressing or sucrose pellets earned across cycle phase. Here on day 1 extinction, there's not a cycle effect in our females, but there is a sex-dependent effect with overall higher day 1 active lever pressing in our females compared to our males. So in some of what I've shown you, well, first, what I didn't show you, the previous literature showed that cocaine self-administration and extinction decreases the activity of AMP-K as measured by phospho-AMP-K, and it showed the use of that other drug to modulate it to increase the activity was able to impact reinstatement. So that was done in male rats, and we replicated. We have preliminary data replicating that finding in female rats, but in terms of what I did show you, so there are a few sex differences in cocaine, subtle sex differences in cocaine self-administration behavior. So while there's no difference in total cocaine infusions, we did see that increased intake adjusted by weight in our females across both cocaine and sucrose. There was this tendency for them to not lose their lever discrimination during extinction, but we didn't see really significant estrous cycle effects on intake or lever pressing during self-admin for sucrose or cocaine. We found that metformin in the nucleus accumbens core is able to decrease cue-induced reinstatement for cocaine seeking without decreasing locomotor activity. But perhaps caution is warranted in terms of this use specifically in females, because cue-induced sucrose seeking was also reduced by metformin in females, indicating it's perhaps not a selective effect, and or maybe there's some dosage considerations or adjustments that need to be made. And our time course suggested perhaps delayed initiation of metformin effects in males and or lower potency of effects in males. And so I put this here to kind of just highlight how potentially complicated following up on these findings could become. And so we've done these studies with metformin, using it as a tool, we think, to modulate AMP-K, but already highlighted the sort of multiple mechanisms of action associated with metformin. As well, one recent paper showed in vitro that greater than 700 proteins were altered by a metformin treatment. And you can see that, I mean, downstream of AMP-K itself, there's all these signaling mechanisms that are affected. So in terms of our future directions, kind of probably the first thing we want to do is confirm this relationship that we're assuming between metformin and AMP-K, and then sort of downstream of that could initiate basically 2 parallel lines of research. So with AMP-K itself, we're interested in potential cell type dependent effects and maybe understanding if there's any subunit specificity associated with specific cell types or brain regions. Again, all that upstream and downstream signaling involved, alternative pharmacological approaches to get at that, because kinases are notoriously hard to drug, and there's potential for circadian rhythm involvements, which, as I briefly mentioned, that's what I did my PhD in. So that'd be interesting to kind of come full circle and bring that back into it. On the other side of things, continuing to follow up on the potential of metformin. So dose response effects of central and then moving into systemic administration of metformin on cue-induced reinstatement. Testing different phases of addiction and different modalities of reinstatement. And then continuing to look at other non-drug behaviors as well. So not just locomotor activity, but perhaps impacts on learning and things like that that would also need to be sort of looked at. And then continue to be more mechanistic effects on morphological or physiological changes associated with chronic cocaine use. And so kind of highlighting, again, another one of the areas from the previous slide. As neuroscientists, we're often kind of very neuron-centric. And so I think it's assumed, we're assuming that our metformin effects are probably on AMPK in neurons. But again, this protein is this important cellular energy sensor. So I think it'll be important and interesting to investigate what are the potential metformin or AMPK dependent effects going on in astrocytes, and especially given kind of what we know or we're starting to appreciate about the importance of communication between astrocytes and neurons and their involvement in relapse and substance use disorder. And so to end, bringing it back to the clinic. So a few months back now, when I looked at kind of what's currently recruiting in terms of metformin on clinicaltrials.gov, you can see that there were 350 studies at the end of October last year, covering a range of diseases indicated here. So there's a lot of interest in this drug. You can see there's at least one addiction-related area. So apparently it's being investigated for smoking cessation. But I think there's still sort of a lot not known. The last thing that I'll highlight, that it's sort of I'd say the most interest around this drug right now is actually in terms of aging. And so there's several large-scale clinical trials in progress or about to be in progress, including this one, TAME, targeting aging with metformin. It's a multi-site clinical trial, with the idea being sort of there's multiple sort of retrospective studies that have identified these positive effects of metformin in type 2 diabetes subjects in terms of reduced mortality, but now looking in non-diabetic subjects to see kind of if it has positive effects in terms of natural aging, and with perhaps the indication that there will be people that will be positive responders and non-responders in terms of effects of metformin, and again highlighting the future of personalized metformin therapy. And so maybe eventually we get to the point where we kind of identify or understand the same thing in terms of personalized metformin treatment for cocaine use disorder. And so I'll re-thank everybody in my lab, and again highlighting Lexi and Amy, who really carried the bulk of the work. And this is the group. And with that, I can take questions, and I'll stop sharing so that I can see people perhaps.
Thank you so much. This is really great, really fascinating. I know a bunch of people had 2 o'clock classes, but and I'm sure they were very interested. And I just want to, if it's okay with you, open it up to see if anybody has questions.
Sure.
And I'm sorry you can't hear the round of applause. That's the big downside of Zoom. Any questions for Dr. Spencer? A lot of clapping. How about 388 students? Do you have any questions? So Mike pulled on?
Yeah, didn't want to get in the way of students asking questions, of course. But one question I had is, this is usually something that I associate with treating type 2 diabetes. If you give metformin in a dose, and I know you're infusing directly into the nucleus accumbens, so it's hard to relate, but would you expect that giving a metformin to a non-diabetic patient in a dose that might affect their drug-seeking behavior would affect their blood glucose?
Yeah, so I think that's our next step, is to give it to non-diabetic rats at least. And so it's probably something that we're going to measure directly. I think it's a danger, I guess, but yeah, we don't know. We don't know. It could. I think so. I think. And that's the other reason, sorry for like bumbling. It's the other reason for being excited about potentially following up on the AMPK more than the metformin and to see if there's drugs that could maybe be more specific to even sort of isoform compositions that are more brain relevant compared to full body relevant.
Or even that might select one of the downstream, the AMPK has, you showed all those downstream pathways, so maybe something that selects one of them that might be more relevant.
No, exactly. And so, so I've encouraged one of my students to follow up that path more than the metformin itself pathway.
Jeffrey?
Yeah, I was wondering if you could speak more on the side effects or the unintended effects of metformin and whether these issues were in clinical trials, because I believe recently there was this recall for metformin because of high levels of cancer agents found in the drug. And I was wondering if you had any insight on that.
Yeah, so that was the recall is a contamination issue and not a metformin issue. So yes, it's a side effect of manufacturing, not of the drug. But there are potential sort of liver issues at high doses in terms of metformin. And I think that's the other thing that I think would make it harder to have metformin actually be the drug, because I think there will be titration issues, like selecting a dose that only does good things and gets into the brain in enough quantities to do good things.
Other questions? I know students from class had questions. Not sure why they're not asking them, but that's okay. Oh, so there's one in the, okay, so we have a student saying, you already answered all her questions in your talk to me in the chat. You have a question from Vivian in the chat. Although both palatable food and drugs of abuse are strong reinforcers, drugs have specific pharmacological effects, whereas food does not. How different between these two systems are they in terms of synaptic changes in the nucleus accumbens core?
Yeah, that's a good question. So your statement's completely correct, so I won't reiterate it. And we do know that because of the sort of much more increased dopamine response that's initiated by a drug like cocaine compared to food, you're going to see greater sort of neuroadaptations in the nucleus accumbens specifically associated with that compared to cocaine. And so it's, yeah, how different to the second core. We also know like there's specific relapse associated phenomenon in the core that we see only with cue-induced reinstatement for cocaine and not for cue-induced reinstatement in terms of sucrose. So we use the model as a control to kind of make sure that we're not impacting motivation in a way that would be detrimental for everyday life. So the hope always, like hope in general, is that if we're looking for a drug that we could translate, we see an impact on cue-induced reinstatement or on some drug relapse behavior, but not on the sucrose reinstatement. And so we actually got the female data before the male data, and it was really disappointing that we saw a metformin effect in the females compared to the males, or that we saw a metformin effect in the females at all, because that is like troubling for translatability. I do wonder if there could be a dose, if it could be dose response down to where we're not seeing something in the females, but we don't know yet.
So you have a question from Marissa. What drew you to research in the field of addiction?
Well, so I guess I'll tell a long story. So when I started grad school, I wanted to do immunology because I wanted to cure multiple sclerosis specifically, very specific problem in question. And so obviously I'm not doing that. I went to graduate school under a rotation system, so we could rotate across different labs. So I did an immunology rotation. I actually really did like it, and immunology is fascinating. And if I could bring some neuroimmunology, which is becoming hot in addiction, into my lab, I'll do that. I did a microbiology rotation, which I figured out that I didn't really like. And then I did a neuroscience rotation and joined a neuroscience lab. And so that's where we were studying circadian rhythms, mood disorders, and some addiction stuff, although my project wasn't really focused in the addiction area. As I mentioned, it was much more like I did a ton of qPCR and CHIP assays and was looking at a specific circadian transcription factor and its regulation of things involved in the dopamine system. And so I guess kind of what led me to going into addiction was I had been exposed to it in my PhD lab, but hadn't really done projects related to it. And I wanted to take my molecular skills into a more behavioral problem. And that's how I got to addiction and did that for my postdoc, which then kind of spawned into my own lab.
Very cool. All right, so you have 3 more questions in the chat. I don't know if it's, do you want me to read them? Do you want me to tell the students to just ask you out loud?
Yeah, they can ask if they want to.
Yeah, so why don't you all just ask in order, Juliana, Kayla, and Corinna.
Hi. So I just wanted to ask, like, at what stage you see the use of metformin in treatment, and like if you can see this as a sort of long-term treatment for cocaine seeking.
Yeah, those are all like questions we don't know the answer to. I'm curious, I have a hypothesis. I'm curious if it could have a prophylactic effect. So if a pre-treatment before any experience were able to elevate, like say elevate AMK in such a way that then you wouldn't get the neuroadaptation of the decrease. And so then maybe it would, decrease cocaine intake and, have all those downstream effects related to that. We don't know that. We haven't done the experiment, but I would like to see if it has a prophylactic effect. We the very minimal stuff that we've done in terms of looking at other stages, I didn't show because it's not ready to show yet, but I'll just talk about it. So we did in a small group of animals, did acute micro injections, again in the core, before a day of self-administration. So they'd already learned, they already acquired self-administration. So we tested to see if microinjection like decreased a day of cocaine seeking after they'd already learned. And it didn't seem to, but the experiment was kind of messy because a weird thing happened on one of the days in the behavior room. So again, it's not clear enough. It's not clear enough for me to show it, but it looks like it doesn't decrease intake in that context. We also looked at a pretreatment before an extinction session. We also didn't see anything, but kind of same deal. It wasn't, we didn't look at day one extinction, we looked at a few days in. And so sometimes by that point, they're already sort of getting to be at a floor. So maybe you're not expecting to see anything. So we haven't seen anything in that limited investigation at those two different stages, but that doesn't mean that there's not something there. And we really need to do more thorough experimentation.
I think I'm next. So, I asked, like, would it be possible to use metformin for people who suffer from alcohol use disorder? And then Corinna's was kind of similar to mine, so I feel like you could probably maybe do both. Or she asked, like, do you think it could be used for other forms of addiction in the future as well?
Yeah. I'd say definitely maybe. It's the one study that I'm thinking of. There's like two papers I'm thinking of. So there's one study where it's been looked at, and I think this was metformin and not a different AMK drug, but I think they used metformin exactly after, like in a nicotine withdrawal context. This is mice, so they made them nicotine dependent with pumps, and then they withdrew them, gave metformin during the withdrawal period, and they showed that there was a decrease in sort of the negative affect associated with nicotine withdrawal. And so based on that, I mean, it's one study, one small finding, but based on that, that might indicate that maybe you could have some utility in terms of nicotine dependence. And the other, I guess, interesting thing about nicotine, and it's already in a trial, so people are already onto this, is that there is that actual connection between smoking and diabetes. So dual benefit there potentially in terms of substance use and diabetes. In terms of alcohol, which is your specific question, I'm thinking of one study that looked at, I think, a cross sensitization between alcohol and cocaine, and so it wasn't a metformin study, but it was like looking at AMPK specifically and AMPK protein levels in this cross sensitization context. Since I can't actually remember what the data was, I can't tell you for sure how promising it was, but I know it's one of the studies that I told my student to look up for her project.
So Corinna, I think your question actually got sort of answered. Under Kayla's, or do you want to ask?
No, I think it was good. Thank you.
Okay. Any other questions? Oh, Sierra.
Mine's more of a general question. So when the students were presenting on your articles last week, we kind of had a discussion about the meaning of addiction and whether or not it's okay, I guess, to say that diet-induced obesity is an addiction. So I just kind of wanted to hear your thoughts on whether or not you would see it as an addiction, because we talked about how food is essential to living beings. So how can you be addicted to an essential resource? So I just wanted to kind of hear your thoughts on it.
Yeah, and I'd say, yeah, diet-induced obesity isn't an addiction, full stop. So that study was led by one of my good friends, Robin. What Robin was trying to see is that like with drugs, are there a subset of the rats in that diet-induced obesity group that would fall under the umbrella of like meeting the criteria for a addiction. And so I guess like to back up even on that, I think a lot of times we throw around the word addiction because it's like a word we all understand and it's easy to say. Knowing that full well, like nothing that I showed you today was addiction really, in terms of those rats taking cocaine. Maybe some of them were addicted, but I didn't test that a little bit, and so I don't know. And really, usually with the short access self-administration models like I was showing you, so they only get 2 hours a day of cocaine, like that usually doesn't really engender a ton of addiction. You usually have to do long access models to get more of an addiction like phenotype. And even with a drug as potent and rewarding as cocaine, in those studies that are looking at actual addiction or trying to classify which subjects are addicted, it's a subset. It's not ever all of them, right? So, addiction is a specific thing that we like hand wave around that we're studying with these models that aren't fully addiction. And so she was trying to recapitulate what had been done with cocaine in terms of like doing all of the tests and looking at how many subjects had that convergence of meeting the criteria for, continuing to use even, or continuing to seek out the very palatable food reward, even when it wasn't available, and all of those things. And then looking and seeing if in that subset that did meet all those criteria, you start to see more of those adaptations in their brains that look like the drug exposed rats compared to just the sucrose guys that I showed you today that you wouldn't see that stuff in.
Anyone else? This is great. Great question. All right, looks like a lot of people, you gave such a great talk, you answered their questions through your talk. So I think if no one else has anything else, then we should just thank Dr. Spencer again for an excellent conversation. Really, thank you. Yes, everyone's saying you answered their questions so well. All right, well, thank you very, very much. I actually forgot to mention to you at the beginning that we recorded this. And if it's okay with you, we'd like to post it on our little YouTube channel, but if that's not okay with you, that's fine. And feel free to send me an email if you don't want to sort of publicly have the conversation. I should have asked you before.
That's fine.
Okay, thank you. All right, thank you very much.
Thank you.
Thank you.
Thanks,
Thank
everyone.
you.
Thank you.
Thank you.